Hola, muy buenos días a todos. Bueno, supongo que se escucha bien. Mi nombre es Vanessa Krakowski y me toca introducir a quien va a presentar la sesión presidencial. El tema del que vamos a hablar hoy es inteligencia artificial, que es una disciplina que vino a revolucionar la medicina y lejos de lo que a veces se piensa que viene a quitarnos el trabajo, nos viene a quitar tiempo de trabajo demandante para que podamos desarrollar la mayor y la más importante de nuestras inteligencias, que es la inteligencia emocional. La inteligencia emocional con la inteligencia artificial va a crear inteligencia aumentada. Caring for the patient in a wireless world. Eso fue en lo que hizo foco la sesión presidencial de ASTRO 2022. Hoy voy a tener el grandísimo honor de presentar a un gran maestro de la radiooncología, que admiro muchísimo, il professore dottore Roberto Orecchia. Ciao Roberto, come stai?
Bene, bene, bene.
Mi ascolti bene?
Muy bien, yes.
Un piacere di rivederti. Bueno, el profesor Orecchia nos va a estar hablando sobre inteligencia artificial. Bienvenido, profesor.
Gracias. Thank you very much, Vanessa. Thank you very much to SASTRO, the Society of Radio Oncologia de Argentina. I am very grateful and honored for this opportunity. And in the next 25 minutes, I will try to introduce you in, as you said, very promising and interesting topic, that is the role of radiation therapy and combination with artificial intelligence. So I just to give you a short introduction on the topic, starting from definition. There are many definitions of artificial intelligence. One of the simplest is that artificial intelligence is the simulation of human intelligence processes by machine, especially computer system. We have two different types of artificial intelligence. One is machine learning. That means that artificial intelligence can automatically adapt with minimal human interference. So it means that is a self-training for the PC, for the algorithms. And the second type is deep learning artificial intelligence. Is a subset of machine learning that use more complex system, that is neural networks, to mimic the learning process of the human brain. So means they are using a brain-like model. You can see here an example of neural networks. Neural networks refer to a system of neurons, both organic or artificial in nature. Characteristics is that this type of network can adapt to changing the input and generate the best possible result without needing to redesign the output criteria. That means that these artificial neurons, exactly like the synapses in a human brain, can transmit a signal, a sort of real number, to other neurons. Neural networks are constructed from three types of layers, coming from digital imaging, in the case of application in diagnostic imaging or radiation oncology. One layer is the input layer, initial data coming from the neural network. We have a second, hidden layers, intermediate layers between the input and the output layer, and place where all the computation is done. And finally, we have the output layer that produces the result for the given inputs. There are still a debate about the role of artificial intelligence in radiation oncology. Anyway, the prospect is very, very interesting. But today, the status of the art is that artificial intelligence is not a substitute of classical workflow, but an integrative tool to be used in some selected cases, potentially representing a decisive step for improving cancer care. Important tool is that the growth of artificial intelligence should follow comprehensive and multidisciplinary patterns, allowing the correct interaction and integration of all the oncology-related areas on a specific patient. The current experience about the cancer types, there are more advantages shown in breast cancer, lung cancer, and prostate cancer, but also other types of cancer should be considered, and especially we have to include red tumor that still suffer from the lack of standardized approaches. That means that this tool can help in order to give more homogeneous treatment and more homogeneous results. We are in the era of omics science, big data, and clinical oncology today is considered as a precision oncology. We have different ways to generate omics big data, including, of course, the already known fields of genomic, proteomics, metabolomics, and others. But similar to these omic clusters, imaging can be used to produce a dedicated omics cluster that is named radiomics and radiogenomics. That we have here a list of this new omic science. Omic science is absolutely necessary in order to realize precision and personalized radiation oncology. That means to shift the paradigm from technology-driven radiation therapy to biology-driven radiation therapy. And the fil rouge between the biology-driven radiation therapy is to integrate radiomic and radiogenomics with all the other omic science. Precision personalized radiation therapy aims to stratify and precisely treat each individual cancer patient. And today, the use of the state-of-the-art technology and biomarkers to improve treatment outcome and reduce adverse effect. You can see here the complex interaction among the different part or different flow of radiation therapy. Where we are today in with artificial intelligence in radiation oncology. This was a very recent paper that assess the status of artificial intelligence-based device in oncology-related field. We can see that the vast majority of all the associated equipment medical device approved in United States by FDA for oncology-related field, and means that more than 80% of all the devices regarded the area of cancer diagnostic, especially radiology, about 55% of the total device on the market today, followed by pathology, about 20%, and radiotherapy is quite well positioned with about 9% of the total of the device. With respect to the topic or type of tumor, cancer in general is 34% of the total, and the main tools are related to the breast cancer, followed by lung and prostate cancer. But in addition to clinics, artificial intelligence can also be useful in the organization and of the workflow in radiation therapy department, and also for reporting from this structure. And this is very useful. We have tools in order to optimize the workflow and patient staff scheduling, for example, using the natural language processing, NLP. This is the intersection of linguistic, computer science, and artificial intelligence. And this tool offers solutions to convert unstructured text into normalized and structured data that are suitable for analysis or to drive new algorithms. There are a very important part of our area in which NLP can help. For example, in the clinical decision support, in improving productivity, in increasing accuracy, in reporting critical finding and recommendation, labeling of key images, multilingual transformers, spelling errors, synonym, abbreviation, etc., reporting in different version and different language, and integration into multidisciplinary units. You can see here the workflow, well known in radiation oncology, and you can see that all the different part of the workflow can be integrated with artificial intelligence tools, especially machine learning or deep learning in some case. The most frequent area is in the field of optimization and dose constraint and delineation of target, but also synthetic images is important, and there is very many study in order to get some predictive and prognostic model, especially related to the probability of developing toxicity. In this literature analysis, this meta-analysis of the recent literature, we can see that we have a very strong, impressive increase in the number of papers published on peer-review journals. So you can see that only in 3-4 years, we have 5 times more paper with the topic on deep learning and machine learning, and also is starting more recently also the computationalism. That means a very advanced type of subset of deep learning. As I mentioned before, these are the subgroup in which, and the radiation therapy workflow step in which artificial intelligence is employed. You can see that mostly in image segmentation, in outcome prediction, as mentioned before, and also in the synthetic image generation. How we can integrate artificial intelligence and radiomics for patient selections to be submitted to radiation therapy. Just to remember that images, digital images, are more than picture, they are data. And this is the flow chart. Flow chart means that we have a matrix coming from digital imaging. We have to put all this number in computation, and the output is to identify a list of possible radiomic features with regard to tumor intensity, tumor shape, and more interesting high-level features like texture of the tumor and wavelength. So it means that we can create a heat map that is very similar to the map that can be obtained by genomic test, but the difference is that we have a description, not invasive description of the whole complexity of the tissue structure. Why radiomics is so growing in popularity in oncology? This is because it's maybe easier than other procedures. For example, in available technology are used by common use in diagnostic, in treatment, and in follow-up for cancer patients. MRI, CT scan, PET, and digital imaging in general broadly used in the current practice. So we have a lot of data that we can already use in order to analyze and to extract the radiomic feature. And automation enabled by artificial intelligence may increase the quality of our diagnostic and staging procedure. Again, really important is that medical images are widely available during all the disease course and can be also analyzed retrospectively. Medical images show all lesion distribution, overcome the critical limitation of sampling and biopsy, and imaging data can be used longitudinally in order to track their modification over the time. So really seems the ideal procedure in order to have a really full view of the patient also along all the phase of the disease. And in addition, of course, radiomics is not invasive and can be repeated easily. An example of the possible application on precision radiation oncology is the use of MRI PIRADS score in prostate cancer. We know that in multi-parametric sequencing, T2, DW imaging, apparent diffusion coefficient, dynamic contrast enhanced, etc., can very well characterize and to define different grade of PIRADS with benign disease for suspected on real cancer, and also is a sort of gray area in which probably we need to perform a biopsy. And artificial intelligence can assist all this phase in order to overcome some inter-reader variation in the interpretation and attribution of the grade of score by MRI, and in different phase. This is very useful, not if we consider the classic treatment, for example, maybe the MRT on the whole prostate that remain the standard today. In this case, mapping by biopsy may be enough. If we need to apply some high-tech approach, for example, the DIL, the dominant intraprostatic lesion, that means to give more dose, like a boost, a contemporary boost on the identified lesion and a lower dose on the entire gland. Or if we use a sort of partial prostate irradiation, like in breast, that means focal radiation therapy with very high dose using a stereotactic or radiosurgery, and in order to give very high dose in a limited portion of the prostate. So we need a complete assessment of the prostate in order to avoid any missing of possible target in the other part of the gland. But also it is important for selection of the patient and to produce really personalized treatment. For example, the possibility to create some nomograms by radiomics using MRI imaging, but also the mammography, the contrast enhanced spectral mammography, and is fundamental because we need to have preoperative risk stratification, prediction on individual of recurrence, selection of no pathological complete response that are suitable for adjuvant chemotherapy after surgery, but especially in case of pathological complete response, de-escalating radiation therapy. We have some example in literature of ongoing study that are evaluating this possibility. I mentioned it for all the Descartes study that has been recently presented and started with enrollment of patients. Another important prediction in order to tailor radiation therapy in the intermediate risk group of patients, that means patients from 1 to 3 positive node in the axilla. Of course, we have some criteria in order to select the patient for local regional treatment instead of no treatment. But the use of nomogram derived by radiomics and MRI based may be a useful, very useful tool in order to improve our capability to identify this type of patient. Another part really important is radiogenomics. What is radiogenomics? The definition is quite simple. It's a specific application where imaging featured by radiomics are linked to genomic profiles. So it means a sort of mix between digital imaging and genomic test, but also can be used and can be linked other biological parameters behind genomics, for example, from proteomics and metabolomics. So the previous concept of integrated all the omic data. We have two different subsets in radiogenomics. The first one is imaging genomics that predict genetic information within individual tumors. So we can define as imaging genetic biopsies. And the second one is radiation genomics, individual genetic variation that change the normal tissue response and can predict radiotoxicity. The problem for that imaging genomics is trying to solve is that personalized treatments require multiple biopsies from the same patient, different time, diagnosis during and after the treatment, which is not always possible. The challenge is that the use of routine digital imaging as a platform for linking specific imaging traits with specific genetic partners can be discover mutation and gene expression patterns. The goal is to convert digital radiology in genetic assessment of individual tumors. And the plan is develop a bioinformatic pipeline for a correlative analysis of radiomics data with gene expression and mutational data. This is an example of radiogenomics pipeline in 5 different stages. The first is the data acquisition and preprocessing, in which we collect radiomics data and genomic data. The second is the feature extraction and selection from the phenotype in case of radiomics and the genotype from genomic test. After, we have to associate radiomics and genomics data, and we have to create a new map, data analysis, the deep model, of course, a machine learning model, statistical, raw cure, and at the end, a heat map that can be applied for several outcomes like survival prediction, tumor grading, biomarkers, clinical decision, etc., etc. Just is not completely new, this one, but it's not in the current clinical practice. There is a paper on 5 years more than tried to correlate the recurrence score normally used in clinical practice, like Oncotype DX or Oncotype recurrence score or the PAM 50, to correlate these maps with the heated map produced by radiomics, and has been found a strong correlation between the two different systems. That means that the result, the expected result of this type of approach are confirmed to be very, very promising. What about radiation genomics? Radiation genomics, as I mentioned before, is devoted mainly to prediction of radiotoxicity on individual basis. And this because adverse reaction in normal tissue after radiotherapy limit the dose that can be given to the tumor cell, so reduce the tumor control probability. The challenge is to identify individual traits that allow prediction of increased risk of developing radiotoxicity, because we know that at least 80% of the variation in clinical response is due to patient-related factors. The goal is to identify germline variants and somatic epigenetic transcription factors modulating biological response of normal tissue to radiation, and the plan is establish a gene-based predictive test for normal tissue radiosensitivity. The final goal is to apply in clinical setting a concept that has been presented some years ago, and it is the GARD, the genomic-driven radiation oncology. The idea is to give different dose to the patient with apparent disease, apparent same disease, but different dose based on the fact that there is a subpopulation of genomically distinct patients, for example, to identify a radiosensitivity population in which we can give less dose, or as opposite, a radio-resistant population in which we can give more dose. We have already, in an experimental way, some tools that I said has not yet applied in clinical setting. One is RSI, the gene expression-based radiosensitivity index that can predict tumor response and clinical outcome to radiation. And the second one is a well-known historical model, the linear quadratic model that describes the biological response to radiation and is used, as you know, to estimate different radiation fractionation schedules. The gene expression-based RSI, together with the linear quadratic model in the form of GARD, genomic adjusted radiation dose, can serve as the basis for precision medicine in radiation oncology. And we need to have algorithm in order to compute all this very huge amount of data altogether in the same patient. Particle therapy is another example of possible use of artificial intelligence. You know that is increasing interest in particle therapy. I know that also in Buenos Aires is under construction a center of proton therapy. But today we have still little genomic data describing the response of cells or tissue to charged particle. But these available data support the physiological difference seen when responded to densely versus sparsely ionizing radiation, so high lead and low lead radiation. Radiogenomics may be the key to identifying and understanding the molecular mechanism, maybe genes, MRI, or protein expression underlying the differential responses. Biomarker or biosignature that predict low lead radioresistance would be important for the use of particle therapy alone or as a boosted dose. Hypoxia signature and imaging of hypoxic region of a tumor would likely be more geometrically accurate, more quantitative, and a timely methodology for treating this target with high lead particles. And of course, integration of physics, imaging, and tumor biology has the potential to change the conventional approach to radiation oncology. What in the next future? New omic science, that is dosiomic. I don't know if you are confident with this, but we can consider dosiomic is an extension of radiomics. And dosiomic extract feature from the patient 3D radiation therapy dose distribution. So the treatment plan that we have for every of our patient in order to obtain specific spatial and statistical information. Dosiomic parameterizes dose distribution in particular region of interest by intensity, texture, and shape-based feature, allowing a high complexity level of description that is fully distinct from those obtained by the conventional DVH, dose volume histograms. The integration of dosiomic with the DVH could constitute an advanced tool to evaluate radiation therapy plan quality, identify new metrics in order to compute, as I said, the quality of optimization of our treatment plan. A second possible development is introducing dosiomic feature into tumor control probability and normal tissue complication probability model, TCP and NTCP models, overcoming the current limitation of this model. So really a great possibility of improving our analysis. And that's very recently an example of application in so that means prediction radiation, for example, in this case, in the nasopharyngeal irradiation, the risk on individuals to induce temporal lobe injury in intensity modulated radiation therapy to select based on dosiomic parameters what is the best plan to apply in this patient, in this person. Some closing remark, just to close my talk. We can see here very huge possibility to apply artificial intelligence in radiation oncology for the modern clinic. You can see that we can cover almost all the different part of our flowchart, and this is for radiation oncologists, for technicians, for physicists, etc., etc. So that means that all has been made? No, because we have not so mature, and there are many things that still to be done. We need, of course, validation, and means that we need very well-designed multidisciplinary translational study. We need standardization of technique to extract radiomic and radiomic feature and radiogenomic data. We need optimization of the interoperability between the different systems. We need availability analysis of big data, so great capability to analyze, to storage and analyze big data. We need, as I said, training for the personnel, testing of the system, and validation of the tool. There is a problem of data sharing, and we need to protect the data, as you know, as cybersecurity is really a daily problem today. And also we have to guarantee the transparency about the quality of the inputted data. Last, I would like to show you this very recently published 1 month ago. That is important because it's the patient view on the implementation of artificial intelligence in radiation oncology. It's a questionnaire with about 100 of patient that replying, answered this, and with the question about different factors, distrust, accountability of IA, procedural knowledge, personal interaction, efficiency, and being informed, with a score between 1 and 5, and you can see the result. The comments are, the comment as about accountability and distrust is the moderately negative concerning the trust for artificial intelligence used in radiation therapy. About the procedural knowledge, a strong desire from the patient to understand the steps involved in their radiation therapy treatment and to be able to talk to a person about it. Strong preference for personal interaction and not to be treated as a number. Moderately negative towards efficiency of artificial intelligence, but without a strong preference in either direction, and clear concern about the use of intelligence artificial is if a computer gave me the result, I would not feel emotional support. That means that the role of in clinics of the dialogue with the patient consent, real informed consent explanation of all the detail of the treatment is remain really important. And just to close with the Gartner hype cycle, we need the skill, jobs, and technological change to face all the problem, and in order to avoid fraud, increase safety, avoid harms. In artificial intelligence today, we are about in this area that we are triggered about the innovation. We have probably not reached the peak of inflated expectation. What to have to avoid in the next future is the throw of disillusionment, and to reach a slope and a plateau for productivity. That means that artificial intelligence, machine learning, deep learning will be introduced definitely in a clinical setting. And if this will happen, we can realize a new form of radiation therapy is over. Biology driven, but is high definition radiation therapy. That means a treatment, a specific treatment for a specific person. Thank you very much for your attention.
Thank you, Roberto. That was an outstanding presentation. I would like to ask you a couple of questions, if that's okay with you. So, radiation therapy workflow is a complex process. In which steps artificial intelligence may be a good tool to increase quality, optimization, and in the end, clinical outcomes?
So, yes, we expect some advantages, especially in the future. But what we have to know that first implementation of artificial intelligence program is not easy today. It's not still easy. And after the implementation, we need absolutely a regular quality assistant program is really highly recommended. The major advantages that we can expect from the introduction today is about our capability for segmentation and automatic countering. You know that in many radiation therapy departments is already applied. As I mentioned before, it's important to study and to find some prediction, dose prediction and outcome prediction in order to select the patient. Today, the main effort are in establish and to predict radiotoxicity in order to avoid unexpected adverse event in our patient. And in the future, maybe the personalization of the treatment. And an example maybe what I try to show in terms of focal irradiation of the prostate or dominant intraprostatic lesion techniques or simultaneous boost and so on. So it means to identify patient in which this type of treatment, as I said, just an example, can be applied safely.
Okay. Since our last talk, that was maybe October from last year, we had ChatGPT showing up on November 2022, and you know, with radiomics and AI developing at an unprecedented pace. How far do you think we are from achieving radiation therapy guided by radiomics, artificial intelligence, and machine learning?
Yeah, far. The problem is that I believe that there are some concerns. So we have a really a big push by industry because artificial intelligence tools are really a huge business for industry. we are speaking about the moment $1 billion of US dollar, but in the future maybe 5-6 trillion of USD. And this cost, of course, should be covered by the institution, means hospital, means academic research, and so on. And it's not easy to find this type of financial resource. On the other side, we have to create a culture and to create education, starting from the staff, because I believe that there is no clear idea what means artificial intelligence applied in clinical sector. So all of us is speaking about the potential of artificial intelligence. We have to consider that human intelligence is not so bad, at least in most of the people, and we have, of course, to keep attention in order to avoid some risk related. And so means that clinician and staff will be provided with really deep knowledge and also a new vocabulary to explain the main concept in accessible way to the patient. On the other side, we have to explain this basic concept to patient directly in order to reduce concern, because you've seen in the questionnaire that there is some real concern from patient that still prefer and some fear about to have a machine instead of a doctor in front of them. So this is a process that is starting. I believe that in the next 5-10 years will be established the limits and the advantage of this new approach that has been applied also in other sciences, also in other common life aspect, etc. But in oncology and in radiation oncology in particular, so we have, of course, to proceed well, but also proceed with attention in order don't suffer unexpected problems.
Thank you. No sé si alguien del público quiere hacerle alguna pregunta al doctor. Well, with that being said, we are ending our session. Thank you very, very much for your time, your excellent presentation, and I hope to see you soon.
Thank you, Anega. Thank you to all of you. Have a great day. Bye-bye.